પ્રેઝન્ટ નામ કરીશું ને પછી આપણે આપણી સ્ક્રીન બતાવી દઈએ અમે સિલેક્ટ કરવાનું
વિન્ડો બતાવો ને
વિન્ડો ના સિલેક્ટ કરી અને શેર ઓપ્શનથી શેર થશે
કરવું
કરી દઉં છું
પહેલો મૂકી દઈએ ને
કરી દો અહીંયા તો full screen કરી દો
એનો ફૂટપ્રિન્ટનો વાંધો નથી
તો બસ તો સર શેરિંગ થઈ ગયું ચેન્જ કરશું ને
આપણે
હા લઈ
So can you say something, sir?
Sorry, yeah. Should we start then?
Yeah. Are we on?
Yeah, I am on. So should we start then?
Yes, sir. Yes. We can start. We can start, sir. Shall I start, sir? I'll give an introduction, then we'll.
Please.
Very good afternoon to everyone who has joined us on our fourth webinar series from Gandhigram Institute, Deemed University, through its GRI Center, Delhi. We have made this webinar series very interesting with very renowned speakers who are participating in this, and this webinar series has gone international today. I'm really very thankful to our Chancellor, Dr. K.M. Anandai. Very specific for a reason that today's special guest has been referred by Dr. K.M. Anandai, sir. I am very thankful to our Vice Chancellor in charge, Professor Suburaj, and our Registrar, Dr. V.P.R. Sivatma, for helping us running this webinar series very successfully from the start itself. Today we have a very distinguished guest, Dr. Abhijat, Sheth, to speak on a title, Health Infrastructure in Rural India, Challenges and Achievements as of Today. Before getting into this webinar series, let me try and introduce, sir, you are a Himalaya, and for introducing, I have very few words. Dr. Abhijat Sheth has post-graduation in cardiothoracic surgery from Sheth KM School of Postgraduate Medicine and Research from Ahmedabad. He is extensively worked as an academician in various capacities in medical colleges in Ahmedabad. In 1998, Sir has gone to UK for further training in cardiothoracic surgery, where he worked as a senior house officer in registrar in cardiothoracic surgery from Freeman Hospital, Newcastle. He has obtained FRCS in general surgery from the Royal College of Surgeons and Physicians of Glasgow in 2000. Since 2001, Sir has main place of work has been in the cardiothoracic department of St. George Hospital in NHS Trust, London, where he has worked with eminent cardiothoracic consultant Professor Brendan P. Madden. Sheth has a long and distinguished career in adult cardiothoracic surgery, cardiothoracic research, and academia, initially in India and then extensively in UK. He has published more than 20 peer-reviewed publications in prestigious journals like Annals of Thoracic Surgery, 40 the Basic Thoracic Society, World Congress of Bronchology, European Respiratory Society, and American Thoracic Society. His major research and publications are in the fields of large airway intervention and strident fill therapy for patients with pulmonary hypertension. In his 10 years of academic career at St. George Hospital, he has successfully guided a member of specialist registrars in developing competency with endobiochronometry intervention, pulmonology, artery, and catheterization and management of patients with secondary pulmonary hypertension. Sheth has undertaken his MD research degree from London University under the supervision of Professor Braden P. Madden, and MBA Health Executive from Kelly University, Manchester. Uh, Today, sir is the president of National Education Board, which is in post graduation and conducting entrance examinations like NEET in post graduation, and sir is having that accreditation powers also with him. Sir, we are blessed to have you in this webinar series, sir. Uh, I'll be very happy. Our people will also be very enriched with your kind of great experience, sharing this experience with us. Thank you so much, sir.
Namaste, and very good afternoon to all of you. On behalf of the National Board of Examination, I extend my gratitude to Chancellor Dr. Anna Malai, Vice Chancellor and team of Gandhigram University to invite me for this lecture. Very interestingly, initially when I discussed with the topic about the rural health, initially I thought that I'm not as expert as the uh, experts are sitting and educating the students in GRI center, but certainly I am one of the key driver as a doctor and as a resource creator to the medical fraternity. So certainly I have a important role to play. I have to participate to play as a important role in the rural health promotion, and hence I agreed and I did my homework to ensure that we can have a fruitful interaction and discussion with the issue. With this note, I will start my presentation. Uh, it's about the presentation is all about the uh, how we're going to what we have done so far with the rural India as far as the health services delivery is concerned, health infrastructure is concerned, and what are the challenges and achievement so far as on today. So the topic itself divides. It's not dividing basically, but it's our perception of urban India and rural India. Basically, what has happened that uh, India is one of the strongest country with so many villages across the nation and had a very strong rural system. And gradually, in the post colonial era, the urbanization increased, the industrialization increased, and in a globalization era, eventually the urban population has dominated on lot of things in development, progress, and others compared to the rural population. And possibly that perception has been created as well as it has put some disadvantage to the rural population, as everyone thought that the developed area is always the urban population in India. I think lately, after Honorable PM Shri Narendra Modi has came, and the last 10, 15 years of our political governance, and they have eventually understood the importance of rural India, and they focus so many things in the rural India. And certainly the health is one of the most important pillar of the and it's a progressive index of the development of any nation. So certainly health has been focused into the center of development of rural India. What, from my perspective as a doctor in post-colonial era, what I am seeing the rural India from health perspective, that what I will explain. In my presentation, what I am going to do, first I am going to say about what the challenges with the rural India, what are the diseases which is prevailed over the urban India compared to the in the rural India compared to the urban centers, and after that there are two three important parameters which we need to look at to create a robust healthcare delivery structure at the rural center, and that includes the governmental initiatives, the public initiatives, the regulatory agencies initiative, creating a human workforce, etc. So first, I would say that health for all I have taken, as you all are aware, that the WHO in 2018 has developed a theme that universal health for all, everywhere and for everyone. And we have adopted this concept, and we want to move very fast to the concept to create a healthy India. Now, health is not everything, but everything else is nothing without the health, as we all were aware about it. The biggest problem with the colonial rule has created, this is mainly from the medical or the healthcare delivery perspective, is they have separated the clinical and public health services. So what has happened that the focus has too much of gone into the clinical medicine little compared to the clinical medicine services to the public health services. Hence, the integrated model or comprehensive model that can have a universal health access to all the part of the nation couldn't be established. The Indian health sector has two extremes. The one is globally acclaimed hospitals, the best known faculties across the world, and on other side there is a rural part or the regional areas or deeper areas into the states where the delivery of the health is unacceptably to the WHO that they are definitely going to move to a universal health coverage to its citizens. And our national policy, which was published in 2017, prioritized primary health care as a principal component of health system strengthening, and it emphasized that health services should be available close to where the people are. I think this is a very important statement because that justifies that how we going to strategize ourselves, reposition ourselves to strengthen the healthcare delivery into the deeper parts of the country, which is the rural India. The main aspect we will see, every one of us knows that India has given the best HR talent across the world. And then we think that then why there is a problem with us. The main problem is a diversity and dichotomy in the sense that at one place you find the best, at the one place you find the most matured system, while 100 kilometers away or 200 kilometers away, you will find a system which is grossly deficient, uh, and there are a lot of shortcomings. So, and similarly happened in comparison to states also. Like certain states, like when we took a medical education into a consideration, the southern states are far more developed than northern states or northeastern states. So this is what the all about the diversity and dichotomy, and this is something our new policy and new strategies has to balance it, so we can minimize or optimize this issue and we move towards the final goal. The more diverse population, which is in the tribal area, which is in the rural area, stick to the old social health practices, not only the health practices, even they are many times having a rituals which is not recognized by health experts. They go with the religious rituals and lot of things. They believe in magics, they believe in a lot of other procedures, prayers. So that is something that make us thinking that how best we can integrate our education system to ensure that the farthest Indian can be at least prepared to understand their own health needs to the best of their own abilities and for the purpose of the productivity. The traditional medical system influence like Ayurveda, homeopathy, Unani, we all know. Even my original root is from village, so I have also seen that even today, as it stands today, although there is lot of debates about the allopathy and the other medicinal system, but I must admit that the other medicinal system like Ayurveda, homeopathy, Unani, naturopathy, Siddha, they all are contributing a huge by different means to the health delivery in the rural portion of India. The exploited human and material resources to bring the urban India advantage that has disturbed the ecos or balance of the natural healthy environment which used to happen when India was totally dominated by rural country or by villages, and that at that time there was no such divide of a significant divide or significant imbalances of such health and other issues, and that this is one of the main cause that the natural healthy environment both in view of resources, in view of material resources, in view of human behavior, in view of culture, everything has been totally diverted or focused to the urban advantage, India advantage, and that has created the imbalances in the eco. The main rural health issues, if we all come across, is still we are well aware that waterborne infections, infectious disease still take a priority. Is and the health has been a problem before, is improved a lot with the recent measures, but still is a problem, and still this is something which we need to continue to work on improving with all the efforts. The another important is trauma and accidental injuries, which is now more common than before. And the lastly is diseases which is born out of cultural occupational practices, even like addiction, even like tobacco chewing, even like many other ritual practices. So these diseases are also more common in the rural portion of India. The I have taken this 5 years from Dr. Mr. Arvind Kasturi's publication, which I found very interesting. That which are the 5 years that is creating a problem, because these 5 years comprehensively describes everything, like community. Now, community doesn't involve only the citizens. Community involve we all are responsible citizens, and community involves all of us as far as the awareness part is concerned. The access to the healthcare, which is very important, and lately we have recognized that this is the part which we need to address quite significantly. And I will give a simple example. Like you must have seen the AMRI that 108 services established in
Yes.
few states has a huge impact on improving certain health situations in the remote areas of the country, and that made us thinking that why we can't develop a uniform and integrated access to the healthcare. The manpower and HR resource is one of the most vital components of any health issue in India, whether it is rural or whether it is urban. But certainly it is more with the rural health because the majority of the population, majority of our aspirating young generation has to settle themselves in urban area, and that is where possibly we need to discuss how best we can create a conducive environment for them, opportunities for them into the rural India. The affordability is always been an issue, and we always had a shortfall with it. And I must praise the government effort that they all are putting the best into it to ensure that the maximum possible benefit we can pass it to our citizens through the by creating the resources in the healthcare. And last important is accountability. If we doesn't live up to our commitment, if it doesn't live up to our responsibility, then certainly any big missions, any big initiatives, whether it is created by public, whether it is created by community, whether it is created by government, is not going to succeed as desired. The challenges in the rural health system, as even today, is infrastructure limitations. And I just give an example that 49.7% of sub centers, 78% of PHCs, and 91% of CHCs are located in dilapidated buildings. And certainly, this is what we can our resources and the state mechanisms can look into it, and they can certainly focus on area to create much more robust infrastructure. Now they don't need to follow any western examples or anything. We have already got a solid setups within the urban India, so we just need to replicate as best as we can with the available resources to the rural India. The inadequate human resources, as I mentioned already, the lack of focus from medical professional, that is also I have mentioned that although there is a huge debate about between the medical professionals and I would say the allied professionals, but the problem is when it comes to the level of giving the health delivery in the rural areas, still the rural areas have a significant lack of allopathic medical professionals, and that is something which, as a regulatory body, is our responsibility that we should look into it and try to correct as best as we can. The unregulated medical professionals is a problem, but as you see, that government is already started regulating the medical professionals in a much better way. They are participating more and more doctors into the healthcare planning, healthcare strategies, and certainly this is going to eventually help with the more better regulations of the regulations. I never say the regulation is always a punishment or regulation is always an enforcement. I think the regulation is in the way that we need to care our doctors, and at the same time we need to make sure that our doctors delivers what they are committed to and what the nation's expectations from them. That is all about the regulation and enforcement. And position, and our continuous efforts are always going to be there. The limitations over the vaccination program, which we all aware, the integration of medical research methodology. I think this is something where now the new policymakers, the new strategist has to ensure that they must increase the focus on research. Now, research is doesn't mean that the things has happened in the lab or things has happened in the big scientific institutes. Any research, even the public health research, if it is useful to the purpose, I will just give you a simple example. Like if you, it's not been done widely or broader, but like if you convert the from pH of water from normal to alkaline, certainly there are claimants that you can improve the health of individual, you can improve the health of adults, you can increase the immunity. Such research can be done, should be done, and as and when required, we should conduct the appropriate trials to create an evidence-based support to such research so we can integrate into our care center, how best it is developed, how so well it is planned, and at the same time, if we see our the rural centers, as I said that we are still having lot of shortcomings into rurals. Now that doesn't mean that we are not delivering healthcare to the rurals, but certainly this was the urban healthcare years before. Now they have converted into such a more modern facilities. It's a high time that our strategies, policymakers, and the state mechanism certainly advances ourselves, our mechanism to move into state of art infrastructure as best as they can. I'm not saying that they can't, they can create everything state of art, but the best to the purpose of healthcare delivery. That is what is the important thing. The key drivers to the rural health is a strong infrastructure facilities, particularly with the community healthcare center, private healthcare center, and sub centers, the work specific and urban centers, the work specific skilled human resources, as I mentioned. And this is more important than having a simple human resources. I just give an example later on that work specific skill development will certainly modify the way we develop our human resources, and it is going to serve the purpose to address the complexity of today's medicine. So that is something where we need to work it. I will explain you in the reference to the ASHA workers later in the discussion. Then, as I said, the committed medical doctors is a very vital component. Integrated clinical medicine with the public health initiatives, I think that is something we need to move from the colonial behavior to this behavior, that public health system is not a separate pillar. We have to integrate, and when the clinical medicine and public health initiatives and public health medicine will integrate together, we will have a much better and much desired outcomes, particularly in the remote areas, rural areas. The strong integration to the existing secondary and tertiary healthcare services is also going to be very important to maximize our resources utilization. The 24 by 7 access to healthcare with strong emergency care provision, I think I take an example of 108. I'm not saying that 108 has solved everything to the need of the rural areas or urban areas, but certainly the 108 was the one innovation from the government that certainly give us a insight that we can extend such innovations to our need to address the access abilities to the rural areas, to the farthest areas or remote areas. The availability of the resources in terms of medicines, life saving equipments is very vital, and it's again a key driver. Uh, Great center without having all this is not going to serve the purpose which we want. And again, the patient education or the community education is going to be very vital. It's not only the healthcare workers education. The ideal healthcare structure infrastructure should have a universal access to the adequate level, and access without adequate burden. Fair distribution of financial cost for access and fair distribution of burden in rationing care and capacity, and a constant search for improvement to a more just a system. I think the last statement is very vital, that we doesn't stop at one endpoint. The endpoint in principle is endless, and there is always a scope for the improvement. And this is the only way the whole healthcare system, whether we doctors, whether nurses, whether skilled workers, whether branch of medicine, branch of public healthcare, anything, this is very, very vital that we all have always a scope for improvement, and there is no completed endpoints. Although we can establish for the purpose of achieving something at one step, and then we can move to the next step. That's a different matter. It's a part of a strategy. The special attention to the vulnerable group, as the life expectancy has increased, so we need more older population. We have children and women of different ages. So I think vulnerable population is something where we need to increase our focus. Until now, we never have a separate focus on geriatric branch or separate focus on vulnerable population. I think this is something that now with the uh, 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 global India, we must move to develop this concept of taking care of our senior citizens and vulnerable populations. The what government has done to create an infrastructure. So I will have a few slides to show that what government, I'm sure the state mechanisms and even central government must have done much more. And certainly you are the experts and you must be knowing, but what I have done a homework and I have seen that what the government has taken a key initiatives or flagship initiatives. The one was National Rural Health Mission. It was a flagship scheme of GOI, Government of India, in 2005. The rural health development through nutrition, sanitation, hygiene, and safe drinking water, all important components was integrated. A great strategy and great thought. The strengthening of PHCs, strengthening of sub-centers, 24 by 7 PHC services, integration of ASHA workers, Janani Suraksha Yojana. They made all these NRHM was very when it was introduced in 2005, and in first couple of years it was seen very productive, and it's seen certainly a very hopeful, and it is hopeful today also. But what has happened that with the increasing demand and the complexity of the medicine and the implementation, which is a problem for NRHM, despite huge funding and huge focus from the government, as well as lack of the skill-specific healthcare workers, has certainly compromised the theme of NRHM to certain extent, and government is trying to revive it to the need of our rural India. The Rashtriya Swasthya Bima Yojana was the another important landmark scheme for the rural health, which was launched in 2018. It was mainly for the below poverty line, but then lately we recognized that it's not only health is not. We always tell, even in the medicine, that health has to be need based. It should not be linked to the money. Although for the purpose of allocating the government resources to the weaker section, the money part is linked, but health is always to be a need based. And then we realized lately that it's not only a BPL population, but eventually we need to extend such services to the whole rural India, not to the limited to certain populations. Then the another one is Indira Gandhi Maitri Sahayog Yojana, and that was introduced in 2010 by Ministry of Women and Child Development. Interestingly, they have focused mainly on the nutritional part that helps to reduce the uh, young children deaths, and that certainly promotes the health of the children and reduce the children mortality rate. So key stakeholders in this yojana were ASHA workers, Anganwadi workers, and ANM. The then in last few years since 2014, the two big initiatives which I always take it important as far as the rural India infrastructure is concerned, and one is Swachh Bharat Mission, and another is PMJ Yojana. Now, Swachh Bharat Mission, initially people always says that why we are giving too much of focus into this. I have spent my considerable time in United Kingdom, and interestingly, I learned because I did my medical education in the management part there, and we were discussing about how the sanitation facilities were created across the country, and they mentioned about, I couldn't recollect the name of the engineer, few engineers who were still respected in United Kingdom because uh, after the Second World War, they created such a great uh, forthcoming vision, forward vision, and develop the strongest sanitation system across the country, right from the Scotland to the south end, and from the east to the west of the United Kingdom. And that has certainly developed both urban and rural area more or less in a equated way. So this is something, a good principle we can always adapt from different countries who has done great in the past. Uh, the Swachh Bharat mission, I always say, is a part of it. The second important I always learned in that if you self-respect, means if you keep yourself clean, and if you keep yourself, present yourself clean, you can always see the similar changes and expect the similar changes in others, and you can work for others also. So I always feel that this is a very important mission, although it was the missions at the very ground level. So certain people uh, criticized it, but at the end of the day, after a few years of its success, everyone has accepted that Swachh Bharat mission is the way, and pursuance is the best way rather than enforcing it. And let the government invest in the basics of sanitations, water supply, cleaning, water cleaning, and everything. And certainly, this will make a huge reform in the health of the people of the country. And this is where the larger scale public scale initiatives, public health initiatives work even much better than us like an individual doctors. So this is about the Swachh Bharat mission. I don't need to describe because most of you are well aware with it. And the most important is a behavior change, and the people has to understand that what is the advantage of having the Swachh Bharat mission. When they see the difference after participating into this mission or this commitment, they realizes the good part of it, and certainly this is eventually going to change and behavior of the culture of our community. And this is certainly an indirect way or informal way of educating our people towards taking care of their health. So I consider it as a very important step. And certainly you have seen the difference. I'm not going to go into the figures, but I can certainly vouch for it in the sense that it serves the purpose, and we should continue in a way that it is going to improve hygienic conditions of our citizen. It is going to improve the ground level conditions of our citizen, and certainly this is a good public health initiative, great public health care initiative that is going to change, improve the health in a positive way. We are not going to lose anything out of it. So that is very, very important for the Swachh Bharat mission. And we must let our new generations of the insured scheme in the way that it integrates scale of citizens to participate into it. So we can definitely improve the health of citizens of all underprivileged population, not only the one who is BPL. And these are the components. It has both impact on urban health as well as the rural health. The components of a health and wellness centers for the primary care centers, the National Health Protection Scheme, and then the secondary and tertiary healthcare protection scheme. The three or four important components which I see, I'm not the expert analyst of this PMJ, but as a doctor, I am saying that the four important component of PMJ scheme is one, creating a model of financial supports to the deprived section of the society, which is from 1 to 6 or 7. And then also it is integrating the healthcare system, both primary, secondary, and tertiary in a better way. So that is the another biggest advantage which we need, and this is more an objective way to integrate the healthcare system. And the third, the most important, which I see is the most important, is creating a huge number of health and wellness centers, and with the not only the view of only allopathic medicine, but to have a holistic uh, approach to treat the rural India patients, and that certainly will help our citizens to integrate our medicinal system in far better way. And I see that the components, these components are certainly very vital and very advantageous to our citizens of India, and particularly the underprivileged and rural citizens of India, the one who lives in the farthest, one who lives in the remote area. As we see that the world largest healthcare program now it has become the Ayushman Bharat. And despite the many concerns, still the program has been very progressive, and certainly it is going to make a huge difference in the coming years. And certainly, as and when program the advances further, the strategists will put into more mechanism to address that, like national healthcare scheme in US, NHS scheme in UK, we can develop the scheme to the best need of our citizens of India. And there's no cap in number. This is just a mechanism and the eligibility of the PMJ Yojana. This is how the system works, which all of you are very well aware with the PMJ Yojana. And the benefit which was covered under PMJ Yojana was all medical examination, both emergency, intensive, and non-intensive care, all implantation as and when necessary, the nutritional accommodation, food benefits, the complication backup, and the post-hospitalization follow-up. So to move forward like an NHS in the future years. The rural beneficiaries are out of total 7 deprivation criteria. As I said, the PMJ covered all such farm families who fall into at least one of following 6 deprivation criteria. The automatic inclusion uh, uh, is always there in the system. So that covers the living on alms, destitute, scavengers households, primitive tribal group, and legally released bonded labor. This is the milestones which PMJ Yojana has achieved, and my focus, my important focus was the wellness centers, and interestingly, they have now created 1.5 lakh healthcare wellness centers across the country, and this is a really important achievement as far as the infrastructure part is concerned for the rural health in India. Now, what differences has made? So, I have few presentations. I've taken presentation from some publications that so far the good part from our current healthcare system is we have declined in the standard indicators like infant mortality rate, maternal mortality rate, neonatal mortality rate, and this is either we are at a stagnant or we have continued down. But certainly, I think this is where the world system is now have a much more hope and much more faith in the Indian system that eventually they're going to achieve far better scale of success in WHO's theme of universal healthcare for all and everywhere for everyone. And you can see that the life expectancy has increased, the expenditure has increased. There is always a criticism on the government about the capital funding for the healthcare expenditure, but government is certainly working hard on it. And I am not in a position to analyze or criticize on this issue. The next one is the healthcare workers' responses. Now, this is the part where, as a president of National Board of Examination, like others, we play a very important role in delivering the rural healthcare system and to make the system as ideal as possible. Now there are so many responsible organizations right from government of India. The three ministries, there are other ministries also, but three ministries is playing a primary role. That is Ministry of Health and Family Welfare, which is the main ministry. The Ayush Ministry mainly look for all the allied healthcare workers, Ayush, Ayurveda, all the other methods of medicine. And HRD Ministry is mainly focusing on Skill India and the skill development of healthcare workers. Alongside with the ministry, we have regulatory bodies like National Medical Commission, which is just commissioned from original Medical Council of India, and certainly they have taken a huge responsibility to ensure that in coming few years by 2025, along with the National Board of Examination with us, we will ensure that at least the doctors ratio we can reach to the 1:1,000 across the country in a more uniform way. The Indian Council of Nursing, Dental Council of India, National Skill Council, which works under the HRD, which has an integrated private and public sector, and that also has a lot of new forward visions and skills. Homeopathy Council, which is recently created, and also the most important as a health subject for the state is a state health regulatory agencies are constantly inventing sort of initiatives which customize and need to the healthcare of their own citizens of the state. So these are the regulatory. Now, this is where I will just give a idea that how we going to contribute to the rural healthcare from National Board of Examination. I will just explain you that National Board of Examination is a primary examination taking body. It takes all the central post-graduation examination in the country until now, till the next establishes, and it also takes the foreign medical graduate examination, licensing examination, which allows the undergraduates from other countries, the of Indian origin, uh, who can participate into the postgraduate education in India and eventually serve the country. So these examinations we take, we also run the postgraduate DNB courses across the country. And currently we have strength of 10,000 medical doctors per year inflow into the postgraduate medical education, along with the 30 to 35,000 postgraduate doctors with the National Medical Commission. So, and we have certainly taken up the responsibility to upscale our operations in such a way that while maintaining quality, if we can double the number in coming 5 years to provide the maximum possible allopathy doctors across the country. And we have kept the rural India into the mind, which I will discuss now in the later on. The MBA program in the district hospital. So we recently we realized that one of the limitations of our healthcare system, as I earlier described, that there is no coherence between the clinical medicine and the public health system. Even in the similar way, the biggest problem which we have so far is we have two parallel systems of healthcare delivery. The one is the private care, private medical care across the country, and the another is a public medical care across the country, which is totally funded by the government. So what has happened? That both are working in their with their own objectives, with their own plus and minuses, with their own pros and cons. But the biggest bottleneck between them is the integration. The both runs parallel. Instead of having an integrated system of working, the outcome of this problem is underutilization of our healthcare resources. whether it is a human resources, whether it is a beds available for the care. And I think this is where possibly the integration between private and public healthcare is very vital. So the national board, although we serve 78% of the private healthcare for postgraduate medical education, we have now increased our focus into the district hospitals across the country where we can develop our program. This was the initiative was started in 2012, and since we took up our tenure in 2016, we strengthened it further, and we just more want to make sure that we are going much more aggressively to ensure that the initiative doesn't die down and the maximum possible district hospital should be utilized. Every bed should be utilized to educate our new generation medical students, which will be at the huge advantage to the citizens of India, eventually, whether it is rural or urban. To facilitate the learning environment, the NB has introduced the concept of secondary node, wherein neighboring medical college or NB accredited hospital will do the hand holding of the district hospitals in terms of providing academic inputs and supplement their NB training. As a result of measure, currently we have accredited 64 district hospitals and 457 DNB seats, but I would say that this is insignificant. We need to do much more for this, and certainly we are going to go far more aggressive. That we have so many district hospitals in the country, and we are going to do it in a much more aggressive scale in coming years. We have also introduced the reservation of in-service candidate into district hospitals. So the public healthcare services and government is not at disadvantage of utilizing their resources, which can be eventually returned back to the need of the public healthcare services, because we need to see that along with the private healthcare services, the public healthcare services also expand and progress in the way that the trust get established for the people that public healthcare services is not only for managing the epidemics, but they have also important for managing every diseases with their citizens are going to have it. So that is something which we have taken. We have also revived the family medicine through our specialist board, and family medicine is a broad specialty, has its role from womb till tomb, specialty of the medicine which concern with the providing comprehensive care to the individuals and families by integrating biomedical, behavior, social sciences. A family doctor provides primary and continuing care to the entire family within the community. Family physicians deliver a range of acute, chronic, and preventive medical care services, and family physicians as a specialty was explored and used to. The reason why family medicine I am discussing in this particular presentation is one of the very vital component for doctors to serve in the rural India or rural healthcare. And family medicines is a comprehensive general practitioner with the proper training mechanism, and it can definitely serve in a formal way. See, until now, we have informal medical doctors in the rural healthcare system, and this is where the system goes in more in a sort of a haphazard movement. If we establish a strong family medicine system of healthcare delivery within the rural India, along with the healthcare wellness centers, then certainly it will establish a formal mechanism to serve the allopathic doctors to the rural population, which is very, very important. And that's why we have revived the family medicine. And certainly, we are going very aggressively with the family medicine, and we have made a rule that every family medicine physician has to take a professional training in the primary healthcare center across the country, wherever they are studying. for at least from 3 to 6 months, which is very, very vital for the primary healthcare centers to have a trained doctors. And certainly this will also professionally develops doctor, and also it will develop an insight for the doctors that how much need is there in the rural population for the health, and they will be motivated to go to the rural India, rural population for the practice purpose eventually. The another biggest initiative which we have taken is we have started the diploma courses in 8 basic branches of medicine. That includes the obs and gynae, that includes pediatrics, that includes anesthesia. So we have introduced this and others also. We have adopted this from older hospitals like we have taken a brave decision because it's a challenge for us to address all the bottlenecks with the diploma program. But we have taken as an initiative that we have to do it, and we have to do it in the best possible way with the quality of education. And I'm so happy to say that this year we have received in excess of 1,200 applications from different institutes to start the diploma courses. And this is a huge achievement at the starting point of diploma program for National Board of Examinations. So these are the diplomas, as I said, and possibly once this is a new beginning for National Board of Examination. So I'm always of a belief that when there is a new beginning, we have to understand the hidden problems. We have to understand the bottlenecks. Hence, at the moment, we have taken a program which was already running in the MCI before, and we will eventually introduce further more programs once we are ready with our resource mechanism to ensure that we will deliver the best. And after that, we will certainly increase more and more diploma programs to the need of regional and rural population, and as well as the urban population as and where required. So these are the district programs, the start of the district medical programs. The advantage of the another advantage I would say my all colleagues that another biggest advantage of utilizing the resources, it will not only encourage the education, it will change the behavior of the stakeholders of the district hospitals. It will also change the belief or confidence of the state mechanisms to invest more or to focus more and to motivate these hospitals to prepare like a private sector hospitals in future. And I think this is the important statement that let us start an education. Education is a big motivator, is a big change of behavior, is a big change of culture, and certainly it is going to motivate the whole mechanism to invest more, to focus more, and to strengthen the existing public healthcare system in the region and beyond the region to the rural areas everywhere. So that is the primary theme of focusing on district hospitals and starting diploma and starting the family medicine program. The integrated approach, which I feel that it's a very high time that any rural strategists, the rural healthcare policymakers, and rural healthcare experts ensure that whatever the new mechanism they built up, they integrate existing successful programs which is running in the urban areas. Let us take like education and information campaigns to educate our community, our citizens, to utilize the telemedicine in a most extensive way, not only for education, e-learning, digital platform, uh, the integrating the specialist network across the countries from urban to the rural. So the end of the care delivery, at the point of end of care delivery, the care delivery will get far more better. We have seen that even in tertiary care, such mechanisms has worked so beautifully, and the world-renowned faculty has eventually trained lot of doctors through these all mechanisms. And now we must utilize these mechanisms to ensure that our rural healthcare workforce we can create to the next level of competency. It also requires the woman empowerment, the safe water supply and sanitations, which we have already discussed before, the prevention based strategy, which is now largely implemented in the urban medical services to ensure to prevent the explosion of non-communicable diseases, but we can certainly replicate the same prevention-based strategy into the rural healthcare population, rural population, and rural healthcare services. We also need to empower the paramedics to take more and more responsibilities, which is happening. Task sharing to the non-physicians, traditional system of medicine, we must not ditch it, must not forget it. We try to integrate as best as we can, despite having uh, all the debates and arguments, but we still in position to integrate in a better way to provide far more comprehensive healthcare to our rural population. The public-private partnership. I discussed the public-private partnership in the context that wherever the big private players have taken the responsibilities of secondary hospital, or they have taken the responsibilities of a tertiary care hospital, not only private. Let us take AIMS or SGPG, a premier institution. So I take it more as a premier institutions of India or private sector, which is very well established. So what happens that if they start taking care of the or integrate themselves with the primary health care, I think the one concept government can develop in the next few years is let the these premier institutions or well developed, I would say well developed institution, whether it is public or private, they should adopt the primary healthcare centers and they should take care of the primary healthcare centers. And certainly you will see the difference because lot of quality, lot of processes, protocols, and other things, education part will be implemented into these centers. And certainly this is the new innovative ways which can be adapted by the policymakers for the rural healthcare. The effective implementation of national programs like Ayushman Bharat Health Insurance. I just say that let us take it positively. We all know that there are bottlenecks. We all know that there are limitations, but we can't talk endlessly about limitations. We can't talk endlessly and debate about the shortcomings. But let us take positives out of it, and why in during our journey we must amend and must reposition ourselves to ensure that we can reach to the next level of desired implementation of all these national programs to create a strong infrastructure in the rural healthcare. The public healthcare initiatives are same as I said that it's all about vaccination, creating resources, communicable disease monitoring, water quality, injury prevention, asthma, allergy prevention, cancer. There are lots more to do, which is that. Then the way forward in the rural care, what we can do best in the coming years. So that I believe in from this I say that the few important points are one, let us integrate whatever the resources we have available and make it to the best use of our rural population. And this will help us integrate the medicine with the holistic approach. Holistic approach is going to include all the values of our traditional medicine or uh, allied medicine, while ensuring that it works in a more formal way through proper pathway, through proper mechanism. So it should not work in an informal way where the deliveries of this such healthcare is haphazard and doesn't serve the purpose. So it's just my submission is, let us make it more formalized, and more structured, and more protocol based, so it serves better in an integrated way. Then the important is work specific skill, as I said, that I said I'll discuss like ASHA workers. ASHA workers, they are created from the social background. And I must say they have done wonderfully in certain part of the country. But we didn't get a desired response from them only because the ASHA workers were developed and prepared more in a generic way rather than a skill specific way. So that was my submission, that let us move a step ahead of it and develop the skill specific healthcare workers. And that will certainly contribute a huge to the rural population, health of the rural health population. The social education, which is very vital, which is already Bharat Abhiyan is doing, we still need to do more with the nutrition, hygiene, and the other case in the framework of social education. The community education with the disease and prevention, as I said, that every individual must be confident of taking care of their health, and that is the best way of prevention of any diseases. And this is where all these different programs of the government, say tobacco prevention, all sorts of other healthcare prevention, smoking prevention, all sorts of things can be taken care of. Addiction is taken care of. Alcoholism can be taken care of. So, if community will understand the bad effects and they will understand the ill effects of these diseases in the family, then and then possibly, at least I would say the part of them will be changed, will get will modify themselves to the purpose. Uh, Same with the another important submission, I say that the country and the government should develop the primordial health prevention. The primordial health prevention is all about training the citizens in their from the childhood, in their formative years of life, and they can learn about what is the health, how we can prevent, how primordial healthcare is a new mode of prevention. It is a step beyond the preventive healthcare for all aspects. And this will certainly a more education based, more a school education based, and certainly more a communication education based. And if the strategy makers can develop the concept in coming years, it will certainly add to the strength of community education and education of our citizens to take care of their health. And the other important part is the data integration, healthcare data provision with skill analysis and registry. Better we understand the data, better we audit the data, we can understand our limitations, we can understand our shortcomings, and we can reposition and redevise our strategies. So this is very vital that we must use our strongest, one of the strongest IT system in the world. We can use our IT infrastructure and functions to create a strong healthcare data provision with skill analysis and registry. And integrate, innovate, and implement. These three I is very important for success of the rural healthcare provision. That you integrate it, you innovate new things, implement to the best patient needs. As I say, that innovation doesn't mean that it happens in the big institutes or big labs. You can have a basic innovation. Sorry, you can have a basic innovation which you can implement into the system, and these three I's will certainly take to the new height. And always aim for the new high, never give up to that. This is just before ending my presentation. I am showing this paragraph, this photograph. It's a symbolic message. A lady in the rural area is capable of handling a smartphone. Then why we can't change our rural healthcare system to the best of our abilities and to put it on the global scale, and we can succeed with our aim of universal healthcare access for everyone and everywhere. And that is the reason I use this as a symbolic, that if we can do this, we can do everything possible. There is nothing beyond our scope if we have a wish, will, and wills to go for it. With this, my best wishes to all of you. Thank you so much. Please pardon me if anything which I made it not appropriate for you, but I hope that my understanding and my homework for the rural healthcare will certainly gives you some idea how we think as a part policymaker of this big mission. And you can always provide us all sorts of input to us to improve ourselves to the next level. Thank you very much. Thank you so much.
Thank you, sir. It was really very, very wonderful to listen to you, sir. As a layman in medicine, there were people those who don't understand the intricacies or technical words of the medical language. But the way you explained it, it was really, really wonderful, sir. Especially this 3I has opened our eyes. First, we should open our eyes, then only things will happen. It was very fantastic presentation. You have touched on Swachh Bharat Abhiyan, Ayushman Bharat, the Indira Gandhi, this Indira Gandhi
Maitri Yojana.
Maitri Yojana, and this prevention is cure, the wellness centers and other things which the government has conceptualized and which is doing. Most of these things are not reaching the people. That's why people are saying that it is not enough. Or in the other way, our population is so huge that we are not able to reach everyone within a specific time in medical care. It was wonderful, Dr. Sheth. You have made us, you have enlightened in many areas where we can do think of contributing by ourselves. As our Prime Minister always says, if 130 crore people of our country can make one step advance, the country will go 130 crore steps in advance. So that is the message, which is very very impressive. Now, coming down to a couple of questions, sets up we would like to know from you. Uh, I had visited Ahmedabad, and I have seen a very interesting concept which has come up. As you rightly said, we are running parallel systems, like government is running health system and healthcare system, and private is running healthcare system. Uh, I have seen in Ahmedabad that these two are combined and one new breed has come. Partnership. One hospital in Ahmedabad is being started by government, and it has been handed over to private hospital, very good hospital chain. They're coming together to do it something together. Can this work out in the rural area? Can these things can be taken to the rural area so that we may have more access to healthcare? The rural people can have healthcare access.
Sir, two things that the Ministry of Health and Family Welfare, as well as the Medical Council of India, which is the Board of Governors of Medical Council of India, and now it's NMC is just created on the doorstep. They have created a mechanism by which the district hospitals is linked to the private partners. And these private partners are big healthcare groups. The private partners, they are basically a healthcare sort of delivery. You can see the example of Apollo hospitals in Chittoor or somewhere they took up a district hospital. So actually, government is very aggressive to go in this mode of adopting the district hospitals in the region or beyond the region by the private sector to ensure that all the qualities or the protocols or the processes or the infrastructure which is created by the private sector can be replicated in these hospitals and the hospitals can be managed in the best way. I will take an example of Gujarat state government. They have two schemes of government. I just couldn't recollect. The one is green one and the one is the other one. Now, in these schemes, they allow the private sector entrepreneurs to take a hospital and to do all these things, and the payment will be done by the government. Now, I will take an example. The one of the private corporate sector industrialist has taken the hospital in the remote area of Dahod, which is a tribal area, and they have developed the college and medical hospitals. Now, to start with, it's always looks like that it's a mess and everything, but eventually, if you will see after 5 years or 10 years, you will see that you will see one of the very well established general hospitals of 1,000 bed or 1,500 bed into the tribal area that is going to serve the whole population of tribal area and nearby. So government wants to promote this concept, but I think wherever the problem comes is the problems of what you call is the contractual agreements, the commitments, the resource allocation. That is still a query into the issue. But I am saying, I will say that new NMC will also help both Ministry of Health and Family Welfare and the states to ensure that at least the approval of this mechanism will become little bit easier to ensure that the private sector can adapt the public healthcare sector and build up a strong integrated healthcare system. And this will be in the rural areas. So it's not only urban area, to the extent that some of them is also mentioned about creating a rural medical colleges. So this is happening, but unfortunately it is not happening at a pace where it should happen.
Thank you, sir. Thank you so much, sir. Uh, in terms of population, we have massive population, sir. Uh, I understand from various sources from our people that data collected by Indian medical fraternity, uh, like in Corona period, is massive as compared to the world. How do you see that our contribution to world health, India's contribution to world health, particularly in rural, uh, we have learned a lot. We have got massive data. How it can be used.
When I worked abroad, the one discipline, even I was in the same belief like I studied here. Unless you don't publish, you will not stay healthy in academics or stay active in academics. You have to constantly publish You have to constantly debate. You have to constantly take part in criticism, argument, and you have to hello.
Yes, yes, doctor.
So what I say that unless you have we have a massive data, but as I mentioned that our data is not using the analytics, our we are not having the proper registry, we are not having a proper auditing mechanism. Unless we utilize we put this data into a proper fashion of research methodology, proper fashion of, and I think this is where the universities can play a huge
Exactly,
role.
exactly,
And they
exactly.
can play a huge role because if they develop this system, we can utilize this data for analytics to create new innovations, research. Even you let us admit what is AI. AI is eventually based on the data.
It does.
It's a data-driven intelligence.
Yes,
Eventually, that is going to take us to the next level.
next level.
So I think the only issue is we have a lot of data, but we have to make it in a structured way to ensure that we can analyze it, we can have a proper registry of all these things, we can publish it, we can put it into research, we can utilize our resources, our human resources to make sure that they contribute to the research and publications. So I think this is, I am sure that this is something which all the educational university institutions across the country can take a big and deep dive into it to do it successful. We have done it. IT, we have done it successful. We have look at TCS. They have conquered the world. I would say they conquered the world. They are as good a system as any other Western systems are standing,
True.
and it's a credible system. So we have done it. So why we can't do it here also? So let us do it. And the I always feel that university system will be able to do it for us
Great, sir.
when we are ready to provide all supports, whatever support is required.
Great, sir. It's a clue that the higher education institutions should take up and they should take a deep dive, as you rightly suggested, sir. Now, something like you have touched that subject of accountability, doctor. From cholera to corona, earlier pandemic till the late cholera to corona. Uh, what do you see the doctor's commitment or role in rural health in India, doctor?
So there are two issues here. I would say the one issue is most of the doctors now we are responsible for. We as a citizens are responsible for creating these aspirations to our children that they only practice in big hospitals, they only develop as a specialist, they only do it. Now, there are two issues which I would like to discuss, and I will just have a little bit openness into it. Let us take an example of United Kingdom healthcare system, national healthcare system. Now, they have a rural areas, although the rural areas doesn't look like rural area, but they have rural areas. So they have a rural areas, they have a hospitals which is as good as district hospitals, equivalent to the district hospitals in rural centers where there is secondary specialties, no tertiary specialty. What is happening here? Now there are two systems. One is this and one is primary healthcare, where the general practitioners are there. Now the country has created so conducive environment for general practitioners. A, you will be surprised that the consultants are less paid than general practitioners. I wouldn't say less paid, but consultants are almost equivalent paid, but general practitioners have far more opportunity to create their financial wealth, their societal reputation than consultants alone. Because consultant is a part of NHS hospital, while the general practitioner is a part of the community. So they have created such a conducive environment that although the general practitioners have not learnt a great in their educational career or academic career, as far as they serve beautifully to the countryside or to the rural areas, they are respected with their aspirations. I think this is where possibly the government mechanism can do little bit, because if they expect the step only to move from the medical doctor side, it is not going to happen. But one step the medical doctors or medical regulatory or medical fraternity takes, at the same time, the one step government also has to take forward to ensure that the doctors are comfortable and the environment is created for them to work into the rural population. Now, I will give you an example that is it possible or not. I would say it is possible. I will give you an example about the district centers. The district centers, the 20 years ago, 10, 20 years ago, there was no cath lab in the district hospital center, there was no cancer center. Now, if you will see, there are radiotherapy centers in the district center, there are cath labs in the district centers, there are doctors in the district centers. So, why this has happened? Because when this doctor realized that there is a scope to fulfill their aspirations, they move there and they do it. So the one part is to create an environment. Second part is a regulatory mechanism. In a regulatory mechanism, NMC is already working on it to create a universal bond system, number one. Number two, compulsory primary healthcare center attendance. But again, all this we can create. The accountability mechanism also we can create, enforce. But enforced accountability mechanism works less in the doctors than motivated accountability mechanism, or participative mechanism works more in the medical fraternity than the enforced mechanism. So this is something where we need to work on it. And second is to create an environment for it and continue to pursue that. When they will see that rural healthcare population treats them like a god, and they have all the aspirations which they have uh, thought about and dreamed about in their life happens in the rural area also, they will be far more happy to do so.
Thank you, Doctor. Uh, Gandhigram was started with an objective, with three objectives, Dr. Sir. One is rural education, second one is rural health, and the third one is rural sanitation. This institution has contributed a lot in that particular area. Uh, what is your suggestion to Gandhigram Rural Institute type of higher education institutions in contribution for rural health and sanitation? Sorry, you are not audible, sir. You are not audible.
Sorry, two things, sir, I would say. The one thing which I have already told you, that let us help the rural system, rural healthcare system developed in the area where you can develop the networking, where you can develop the IT infrastructure, where you can, because that requires also a lot of education and logistics creation. And this is something where university can join hand with the state government mechanism and establish the network. The network can only integrate, first you create a network. Network won't be able to integrate unless you have created a network within the rural system. So once you create a network in the rural system, once you created a base and foundation in the rural system, the rural and urban system will be able to integrate well. So I think that is the first part which the university can do. The second important is the research. The basic problem, as I said, the ground research, there's a lots of innovation which rural health education can create within their basket. And there is, if they implement the research, I told you an example of providing the alkaline water. There is another example. We are conducting the uh, uh, pharma companies conducting a trial of effect of curcumin on Crohn's disease or cancer or like this. That why we can't create such a sort of structure which, as you rightly said, we have a wealth of data, a wealth of evidences within the rural system. It's a university system, it's an educator. See, I can only admin, I can't be a teacher, great teacher. So the person who has a great teaching abilities which are only in the universities, they can develop this research arm very strong. And the research arm not only strong, but they create their data, they publish, and the publication will give a confidence to the government and every organization that there's a worth going there, that's a worth investing there, that's a worth participating there, and this is what the university will do. The one is strengthening the research in far stronger way into the education, rural health education. It doesn't matter that it's Ayurveda or it's other, but as far as it's evidence based, I think the most important which the university researchers should create, that it establishes the evidence based research protocol, and that will be accepted across the country in much faster and much easy way. And second, as I say, that let us create a strong data retrieving system from the rural healthcare. I think these two is the most important. I don't know how the, unless you have a healthcare education body within your university, then possibly the third arm which I have said is a skill development. We need a workforce which is skill specific, and we need to move from ASHA to the skill specific workforce, and that will certainly change the whole paradigm of rural health provision. That's what I would say. And there might be more, but this is what is coming in my mind.
Thank you, sir. We will try and do it from our end. That will be our commitment to you in this view, sir. I should now come for a formal process, sir, because your time is very important. I know you have taken time for us amidst your busy schedule. Gandhigram Rural Institute is really uh, very thankful to you. The staff and students of the fraternity are very thankful to you. Dr. Abhijat Sheth sir has delivered a lecture in health infrastructure in rural India, challenges and achievements as of today. Dr. Sir, it's I am spellbound. We are enriched. Thank you so much for your time, sir. Thank you so much. Jai Hind. Jai Hind.